USMLE step 2 CK. This will be a platelet disorder. So primary hemostatic disorder part 1, and patient could have platelet disorder number 1. Number 2, vascular damage, both cause bleeding disorder. Platelet disorder, it could be faulty platelet, like the patient with renal disease can have abnormal platelet, and low platelet count like thrombocytopenia, vascular disorder. This patient will have PTT will be normal and bleeding time will be increased. And bleeding time will be normal, PTT will be abnormal in coagulopathy when have clotting factor problem. So what is the bleeding time here? Why we do this? This test used to identify the capability of the platelet to adhere with the endothelial lining of the capillary. So bleeding time will prolong when patient has thrombocytopenia, and if you know the platelet count is low, we know that bleeding time will be increased. When patient has increased bleeding time, platelet is low, then we have to find out the platelet count is low, bleeding time is high, so we have to find out what is the causing of the increase the bleeding time. So in this case, normal count of platelet, blood bleeding time is high. To know what cause prolong the bleeding time, even the patient has normal count of the platelet, like patient with the von Willebrand disease, or even patient platelet count is normal, patient could have abnormal platelet, like platelet does not have the receptor to bind with the fibrin, or the von Willebrand factor, or platelet shape is abnormal, or platelet could not activate due to the shape of the platelet, or environment of the platelet make platelet inactive. How to measure the bleeding time? Engulf the blood vessel with the blood and cut the vessel and measure how long it takes to stop bleeding without any intervention. If a patient has renal failure, patient could have bleeding disorder due to the patient has dysfunctional platelet. Renal failure patient has dysfunctional platelet that can cause increase the bleeding time, but PTT will be in normal. So thrombophilia. What is thrombophilia? Thrombophilia is a hypercoagulable state. So patient has clotting problem. This patient could have factor V Leiden mutation, and in this case his factor is overactive, which causes the hypercoagulability. How to prevent it? Give warfarin for 6 months and keep INR 2 to 3. So how we can get the thrombocytopenia? Low platelet. Where platelet produced? In the bone marrow. So when platelet is low, patient could have bleeding, or even could be asymptomatic. So how bone marrow will be affected that cause low platelet? If patient is alcoholic, patient have myelodysplasia, megaloblastic anemia, hematologic malignancy infiltrate the bone marrow. For example, the chronic lymphocyte leukemia infiltrate the bone marrow, aplastic anemia. Thrombocytopenia due to the non-bone marrow failure. Something else is causing, let's say, immune system produce antibody and breaking down the platelet. So immune mediated as heparin induced thrombocytopenia. Idiopathic thrombocytopenic purpura, hyperesplenism, and the SLE, which also produce the antibody. Sepsis cause the clotting in the blood vessel. Viral infection, which cause the antibody production. DIC, HIV, thrombotic thrombocytopenic purpura, hemolytic uremic syndrome. So SIV patient, if a patient has the low platelet, and it can cause by the, look for the patient has infection with the HIV or not. So HIV patient person has 10% possibility to develop the antibody against the platelet and asymptomatic thrombocytopenia. If a patient has risk to have HIV and also has thrombocytopenia, first test to identify the antibody against the HIV to make sure that patient is HIV positive or not. But usually this patient don't show the symptom of the thrombocytopenia. Epstein-Barr virus can cause the infectious mononucleosis and cause the splenic sequestration to develop the thrombocytopenia. Patient would have generalized lymphadenopathy at the cervical region, fever, pharyngitis. So platelet breaking down at the spleen. If patient has B12 and folic acid deficiency, patient can have megaloblastic anemia and low production of the platelet at the bone marrow, and patient develop thrombocytopenia. Now talk about the heparin-induced thrombocytopenia. So unfractionated heparin can cause hepatic-induced thrombocytopenia. Unfractionated heparin is the most common cause for the heparin-induced thrombocytopenia. Low molecular weight heparin also can cause the hepatic-induced thrombocytopenia. If you give the heparin, person can develop. Usually you give it to prevent the clot, but it can form the clot. And use the heparin with the heparin directly activate the platelet within first 2 days after give the heparin therapy. After that develop thrombosis. After that platelet count will be low, but still we can give the heparin, continue it, and platelet will come back to normal within several days. Even will continue give the heparin, and this is first 2 days of the heparin. Heparin induced thrombocytopenia number 2 cause. Within 4 to 10 days after heparin therapy, patient develop the antibody against the platelet. After that, patient develop the arterial thrombosis due to the antibody activated platelet and make thrombosis at the artery. Heparin-induced thrombocytopenia is an antibody-mediated platelet activation. In this patient, antibody would activate the platelet prematurely So platelet will be removed from the circulation prematurely by forming thrombosis. Normal people have laceration at the skin, for example, and platelet will activate to prevent the bleeding, and platelet will be removed from the circulation and in this case we only use a small amount of platelet, but antibody will remove a lot of platelet that cause the thrombocytopenia. Use of the unfractionated heparin for DVT, for example, after 5 to 10 days antibody produced against to the complex which is formed by heparin and platelet factor. After that, 30% of the drop of the serum platelet count due to patient develop heparin-induced thrombocytopenia by producing the antibody against the platelets. This patient could have thrombosis at both the artery and venous system, but most of the time thrombosis occur at the venous system. So check for clot at the venous system. 30% drop of platelet would usually not cause the bleeding and patient would be asymptomatic. DVT at leg give heparin, develop thrombosis at the upper extremity and complain of coldness at the hand. So no pulse at the hand. Patient develop DVT, you give the heparin. DVT at the leg, you give the heparin. Now patient complain he has coldness in the upper extremity. So this patient also can develop DVT, stroke, etc. due to formation of the thrombosis. How we know that antibody cause the thrombocytopenia? Do the ELISA test. Look for antibody against the platelet factor which cause the decrease the platelet count. Serotonin release acid, because we know that platelet release the serotonin. And fibrin degradation product is negative, rule out DIC. Disseminated intravascular coagulation. PTT will be prolonged if you give the heparin, and PTT will be normal in heparin, but PTT will be increased when you give the warfarin. INR is normal. Platelet count low, normal red blood cell, white blood cell, because the antibody produced against the platelet. CBC, normal white blood cell. Hemoglobin hematocrit would be low to normal. If patient has normal PT, PTT, INR, normal platelet count before the surgery, what does it mean? Patient does not have the coagulopathy or platelet deficiency. If patient has low platelet and high PTT after the surgery and patient was on heparin, heparin caused the patient to develop the coagulopathy. So for this patient, monitor the PTT. So monitor the PTT. Used to monitor the anticoagulant level of the heparin. So use the PTT to know the activity of the heparin. Usually PTT will be high when you give the heparin. What you have to manage this patient? Discontinue all kind of heparin and give the enoxaparin, enoxaparin for the DVT. Do not switch one heparin to other. And number 2, you can give alternative treatment for the heparin such as danaferrate and on direct thrombin inhibitor such as argatroban, vibalirudin, lepidudin. After give the direct thrombin inhibitor, you can give the warfarin. Don't give the warfarin directly, and don't give warfarin alone. Do not give warfarin as long as platelet count will be greater than 100,000. If just give warfarin, a patient with DVT has increased risk to develop the gangrene at the limb. So clotting factor will become worse. Don't give platelet which may cause the ongoing thrombosis even worse. So never give platelet, even platelet count will be low. So don't give platelet as long as patient is asymptomatic. Platelet would be used to form the thrombosis. If you give platelet, it becomes the clot, make things worse. If platelet count is very low and patient is bleeding, give platelet. But usually a patient with heparin-induced thrombocytopenia would not have very low platelet that we need to give the platelet. Very severe bleeding case, do the plasmapheresis to get rid of the antibody. So now look at the note. DVT. Patient cause is complaint of the cup pain, and in this case you give the parental heparin. After that you give the oral warfarin, and follow this patient by following the PT-INR used to monitor the anticoagulant effect of the warfarin. Platelet count release we talked before, now talk again. Platelet would release the serotonin when platelet would contact with thrombin, collagen, antigen antibody complex. Adenosine diphosphate heparin could induce to produce antibody against platelet factor. Heparin could induce to produce antibody against platelet factor. So heparin cause the production of the antibody. Essential thrombocytosis. What is essential thrombocytosis? Platelet count is high. Marked increase of the platelet in serum, say greater than 1 million. Patient could develop thrombosis and bleeding. Number 2, if this case genetics can play, and patient could be positive for the gene of the JAK2. So JAK2 mutation can cause the increased platelet in the serum, which could be even greater than 1 million. If patient has infection, patient has cancer, patient has iron deficiency, that can cause the thrombocytosis, that means increased platelet count. So what we have to do, this guy, if this guy is less than 60-year-old and platelet count is less than 1.5 million, there are no symptom in this case, and there is no thrombosis going on, there is no bleeding going on, we can just follow this patient. And if this guy is greater than 60-year-old, platelet count is 1.5 million, and he has a symptom of the thrombosis and bleeding, give this guy first hydroxyurea to produce less amount of platelet. If hydroxyurea suppress the production of the red blood cell, just because it can cause the aplastic anemia, in this case give anagrelide, ANAGRELIDE. Patient with thrombocytosis, very high count of thrombocytopenia, platelet can develop erythromelalgia, and patient will complain of the painful red hand, and in this case give aspirin.